So welcome to the conversation in interventional cardiology on computer tomography angiography for PCI planning. My name is Natalia Pinilla. I am an associate professor of medicine at McMaster University in Hamilton, Canada, and also an interventional cardiologist. And I had the honor to be the guest editor of the SCAI special issue on the role of cardiac computer tomography angiography in cardiovascular risk stratification, diagnosis, treatment, and prognosis of cardiac disease. We are here today to discuss two important review papers published in the special issue. The first paper is Advanced CT Imaging for the Assessment of Calcific Coronary Artery Disease and PCI Planning. And the second paper is Cardiac Computer Tomography Angiography in the Evaluation of Coronary Artery Disease, an Interventional Perspective. I'm joined today by an amazing panel of leaders and experts in this field. We have Dr. Carlos Collet, co-director at the Cardiovascular Center All Als in Belgium. We have Dr. Jeffrey Schussler, the Chief Medical Officer at Baylor University Medical Center in Dallas, Texas. And we also have Dr. Daniel Jones, a clinical senior lecturer in interventional cardiology, clinical trials, and consultant cardiologist at Barnes Heart Center at Queen Mary University of London. Thank you so much for being here in this conversation today. And I think we will begin with Dr. Schussler on the cardiac computer tomography angiography in the evaluation of coronary artery disease and interventional perspective. Dr. Schussler, your paper is amazing, and I'm really impressed by the amount of cases and such a nice practical way you're putting out there the role of cardiac CT. So tell us about your paper.
Well, first of all, thank you for having me. I'm very honored to be here. So we've been doing cardiac CT it's been about 20 years now. And as we were talking before we started the meeting, this is something that originally I sort of envisioned interventional cardiologists as being the tip of the spear reading cardiac CT. As time marched on, we seem to see, number one, a lot of radiologists who are reading, which makes sense since it's CT, and a lot of general cardiologists. But when I think of cardiac CT, at least for chest pain, there's usually two questions that we're asking. Does a patient need to go to the cath lab, and does a patient need statins? Those are fundamental to when we're looking at coronary disease for chest pain. And, the interventionalists gain a lot of information as far as who needs to be taken care of with more invasive procedures. But there's even some nuances that I think that the current reading specialists should probably be focused on, and things that affect us in the lab. What kind of guides you use? How long is your lesion? Whether this is going to be an easy or difficult intervention. And I think there's a lot of room for uplifting or uptraining some of the readers currently so that they can help us out when we're in the cath lab. I know that a lot of times these days, when someone's coming to the lab with a CT coronary is the reason for going to the lab, I spend a little bit of time looking at the images and making sure I know what I'm going to expect once I'm doing the intervention. So I thought this is a very helpful perspective. It's really focused on how this technology is helping us as interventionalists in the cath lab.
Yeah, I was very impressed by the amount of cases, and I'm pretty sure the readers are going to enjoy how many indications are out there, that you could consider a cardiac CT. So I would want to listen Dr. Jones' perspective, now that cardiac CT is so important in not only in diagnosis, but in PCI planning, in pre-cardiac surgeries, in cardiac masses assessment, how do you see the future of cardiac CT, not only in interventional cardiology, but cardiology?
Yeah, so it's a great question, and thank you for the opportunity to be part of the panel. And I'd like to start on, again, congratulating Dr. Schussler on a great paper and a great overview. As you said, it's a very practical guide to how you would use CT, and I think it reflects how not only we can use CT today, but also how we could potentially use it tomorrow. I think, as you've said, or covered, the future of cardiac CT is very bright, and I think as more and more literature is available and more interventionists become comfortable with the technology and how actually you can use it exactly as described in the manuscript. And I think a lot of people still don't appreciate a lot of the practical aspects of this paper. You're only going to see greater utilization. I think some of the bits, I think I'd need convincing of my cardiac surgeons that they're still happy to have CT rather than invasive angiography. But I personally, believe that it is as the paper suggests. But I think they may need convincing. But I think that's probably part of the discussion.
It is. I mean, I see the evolution of this where, it used to be that we'd read a cardiac CT once or twice a month. And now, right before this meeting, in fact, I got a call from one of my cardio-oncology colleagues, and she's asking, can we do a cardiac CT on this inpatient who has a new cardiomyopathy? I mean, it's become very front of mind for a lot of people as far as the frontline test for answering a lot of questions. And I'm glad you appreciate the examples. The reason I have all these examples is that we're using it day in, day out now. It's become a very practical daily use tool to the point where we're, looking to increase the volume and the access because it's become so necessary.
Dr. Schussler, I had a question for you. You also had some of these cases post-cardiac surgery, right? Like as an interventional cardiologist, we know how challenging it is to bring these patients with previous CABG or previous cardiac surgery to the cath lab to check on bypass patency or new issues post-cardiac surgery. How do you see this? Because as an interventional cardiology, I see there is a lot of potential of cardiac CT in this setting.
Cardiac CT for vein graft patency is actually really, really useful. I don't think we utilize it as much. As opposed to native disease, I think it's actually easier. Usually it's a binary question, is the graft open or closed? You rarely see a 90% stenosis. Graft's either there or it's not. But it's really very easy to look at just the 3D overview and see if they've got 2 grafts, 3 grafts, make sure that they don't have any issues. I think one of the reasons I lean away from cardiac CT sometimes is that you're surprised if someone had a 5-vessel bypass 10 years ago, you're almost guaranteed that a few of those grafts are no longer functioning. And do you really want to know that if they're doing okay? So it gives you a ton of information. You just have to be careful what you ask for.
Yeah, I totally agree with that. You have to understand what you want to know, because once you do cardiac CT, you see everything, absolutely everything. And one other question I have for you, like, cardiac CT is becoming one of the most useful tests, like pre-coming to the cath lab. How do you know from the interventional perspective, but from the patient perspective, how do you think our patients feel having such a test with such information in the understanding of what's going to happen in the cath lab?
Yeah, I don't know that it affects the patients as much as far as the cath lab experience, but I do think that what we're seeing is a shift. Even these days, we see up to 40% of our heart catheterizations do not end up with an intervention. And there's definitely reasons to do diagnostic caths, but I think most of us would prefer not doing diagnostic caths if we don't have to. We enjoy doing interventions when they're meaningful and helpful, but just saying, hey, your arteries are okay and off you go, we would probably rather not utilize the expense and the small risk. So I think trying to weed out people who really need to be in the cath lab versus those that may not is very helpful. So I think that alone is very good for patients who get a lot of information up front. Do they need a heart cath? Yes or no? Should they be on risk factor modifying therapy? Yes or no? And some of the biggest benefit, honestly, is in the patients who don't need to go to the cath lab, but definitely need to be on therapy like statins. And I think that's probably the best bang for the buck versus the ones who, you've got a very tight proximal LAD stenosis, you're going to get a stent.
Yeah, thank you for that. And after reviewing your paper, I'm pretty sure all the readers are going to enjoy all of those cases and those options. This is just going to open the minds for everyone in the indications of cardiac CT. Thank you so much, Dr. Schussler.
Thank you.
Okay, so that brings us to Dr. Collet's paper on advanced CT imaging for assessment of calcified coronary artery disease for PCI planning. And Dr. Collet, like, you have transformed like the way we use cardiac CT. And one of those ones that you bring out in this paper is very interesting, because calcium score was just a number, like in the beginning of cardiac CT. And now you're putting in this paper such a beautiful description of the calcium assessment. So do you want to explain us what is your paper showing us?
Yes, Natalia, thank you for having me and for the opportunity as also for to SCAI. And I think what we try to compile in this paper is actually what we see that the future holds for cardiac CT in terms of calcium. So it's extremely interesting for me to see that in 10 years ago, having a lot of calcium, a high calcium score, was almost a limitation for the technology to do a diagnosis in terms of obstructive or non-obstructive disease. Now we see calcium, or we see the ability of CT to detect calcium as an advantage in order to understand how severe is the calcium, what is the circumference of the calcium, the length of the calcium, the thickness of the calcium. So these are things that can be extracted from a non-invasive tool before the patient actually is in the cath lab and allows to prepare yourself for what can be a complex PCI in the context of a severely calcified disease. So this is kind of the basics of the calcium analysis by CT. Now in the paper, we take one step further than that, and is introducing the possibility of CT to stratify calcium, not only based on the morphology, but also based on the density. And this is something that is unique for CT. In other words, the higher the density, the harder the calcium is. And this is a capability only from CT in terms of having a stratification of how hard or not hard or soft the calcium is. And I think this is going to be the future in terms of PCI planning, advanced calcium modification, device selection, etc.
Yeah, it is like an eye-opening reading the paper when you describe about this density, because I totally agree. Even other technologies and even invasive technologies will give us information about the presence and the extension. But this density, how hard the calcium could be, is something that I totally agree that will come just for cardiac CT. Reading this paper comes to my mind, Dr. Collet, how do you use the CT information when yourself are in the cath lab? Do you display all of these beautiful images in your cath lab? Like, how do you use this information? How do you bring the two worlds together?
I think there is something that Jeff mentioned at the beginning of the conversation that is crucial. You have to look at the image. You cannot read the report. Basically, the reason is that the people writing the report, they're not doing PCI. So you are speaking different languages. So you need to look at the calcium, you need to look at the anatomy. So open the packs, look at the images, look at the calcium, and it's going to be very intuitive to understand the coronary tree, basically because we're looking at that every day in the cath lab. And when you look at the tomographic protection of the vessel, it looks similar to IVUS or OCT. So these are images that you are familiar with. Now, it's also true, Natalia, that analyzing a coronary CT from the diagnostic point of view is time-consuming. You have to do a number of clicks, and this is not the same tempo that we have during a coronary intervention. So for that reason, we have kind of simplified the way that the information is displayed. This is basically taking the same information that you have in a coronary CT, but making it 3D. So basically what you will see in the paper are beautiful pictures of calcified structure in 3 dimensions, where it becomes extremely intuitive to understand not only the presence of calcium, but the location of calcium. We have a nice paragraph or section about something that we have been developing in the last few months, which is basically where is the wire or the prediction of the wire location relative to the calcium. This basically means that you can predict device crossability or success of ablative therapies like rotablation, etc. And all this is thanks to the ability of CT to provide the information in 3 dimensions.
Yeah, great explanation. I really see you like using all of this information in your procedures. And for Dr. Jones, how do you see we have had challenges in the adoption of intravascular imaging, and we have been facing this for decades now. And now with these papers and Dr. Collet's motivation and telling us that actually you can use cardiac CT information for plaque morphology, physiology, landing zones, plaque assessment, and now calcium density and extension to plan your procedure. How do you see in the future the intravascular imaging role compared to this cardiac CT role? Is this going to be better adaptive to our practice?
Yes, it's an excellent point. I'd like to congratulate Carlos on what is it's a paper for the next century rather than our current practice, isn't it? As in some of the concepts are just beyond what anyone can imagine they'd currently be able to do, and it's amazing what could be done in the next 5-10 years in terms of getting that information from the CT. As in knowing whether you need to rotor or whether you can deliver an IVL, whether the calcium can be cracked. All of that's it's very it's coming, which is great. So I guess from the imaging perspective, you could take a binary approach and say, actually, watching or reading Carlos's paper and looking at the presentation, do you need imaging? As in, everything you need, you get from the CT. It's just about whether the stent result is acceptable with the imaging at the end of the case, because you know everything else before you start from the CT. But I think actually I would see them as being synergistic. As in, the CT tells you what you're going to find. Any interventionalist can open a CT scan and see a lump of calcium and know that the IVUS has to be open or the OCT has to be open. It should tell you that some people say 100% of PCI should be intravascular imaging optimized. You open a CT scan, there's calcium. Of course you have to image. And I think that just that first step, anyone can get from a CT scan, and all the other bits will come and we can learn. But I think that bit is synergistic, and it will improve people's understanding of imaging, because the CT has a lump of chalk and there's dropout on the IVUS. It's calcium. You can't misinterpret that. So I think it will increase imaging rates and increase the adoption of that technology and the skill in which people use it.
Oh, thank you, Dr. Jones. That's a very interesting perspective. And I agree, it's like a binary approach. And just using those concepts that you were explaining, I think this brings us to another question to Dr. Collet, is like, how do we validate all of this information we get for cardiac CT in the real procedures? You're doing amazing job with ongoing studies. So do you want to share with us about the P4 study and the validation of these concepts?
Yes, so I think that we have been kind of understanding the role of CT for PCI planning, and I think most of what you need to know is in the paper of Jeff and in our paper in SCAI. There are additional elements like understanding the mass at risk, the physiology, the prediction of the PCI result with FFRCT planner tool, etc. So what we have designed is a randomized clinical trial. We call this the P4 study, which are basically randomizing a little bit more than 1,000 patients to either what we call CT-guided PCI, which is the amalgamation of all these elements that you can extract from the CT relevant to PCI, including online guidance. In other words, the CT next to the angio to understand live where is the plaque located, extension, etc. And we're comparing that to what we believe is the best way to do PCI today, which is imaging-guided PCI. So the control arm is IVUS-guided PCI. We are midway, so we have included around 50% of the population. We think we're going to be ready in about a couple of years. So keep tuned. This is a field that is emerging, is growing, and data from a randomized clinical trial will be available very soon.
I'm listening to this and I'm so impressed. This is something that surgeons have had for years as far as pre-operation planning. They look at CTs, they know what they're going to do. Cardiologists, in the cath lab, we're very reactive. We sort of say, okay, well, we think you need to be here. We figure out what you've got right on the table, and then we figure out what to do. This is very exciting to be able to say, okay, well, I already have a good understanding of what I'm going to do, and this is how I'm going to do it.
And we believe, Jeff, that, coming to a procedure, understanding which is the guide you're going to select, from where to where is the plaque, what type of calcification are you going to face, is going to really change the way you approach the procedure in general. So I think this is going to really represent a shift in the way that we approach PCI. And I think that the role of CT for PCI planning will just keep growing and growing.
And that's very exciting. And the calcium, I got to give you kudos, because calcium has been such a kind of a black box. We say the coronaries are all calcified. Well, we'll deal with it when we get there. So being able to actually utilize that and embracing, say, this is the calcium, we know where it is, we know what we're going to do with it. It's going to be wonderful. Yeah,
this is an amazing and exciting feel. And the way this conversation went, we start doing some questions. And at the end, I think there are more questions that are going to be answered in the future. And I think a good message for the readers of this SCAI special issue in computer tomography angiography is that there are unlimited options that we are all learning, and this is a field on development. So thank you so much for this amazing conversation. Thank you for the authors for those amazing papers. And we really hope the readers of the SCAI special issue enjoy as much as we have enjoyed preparing this for you. Thank you so much.